All right, we are very excited to be here today with Dr. Dustyn Williams. Now, Dr. Dustyn Williams attended undergraduate at Yale and medical school at Tulane School of Medicine. He's a board-certified internal medicine hospitalist at Baton Rouge General, and he's the clerkship director for Tulane students in the lead curriculum and core faculty for the Baton Rouge General Internal Medicine Residency Program. He's also the co-founder and lead educator of Online Med Ed, which we'll learn a little bit more about today, and which is a clinical learning platform for health professionals. And he's the co-founder and chief medical officer of Dose Doctor, which we'll also learn a little bit more about today, which is a diabetes management telemedicine platform. I personally have had the pleasure of working with Dr. Williams to develop an evidence-based nutrition curriculum for medical students and for physicians, and we're going to be releasing that later this year. So I won't talk too much about that right now, but thank you so much for taking the time to be here with us today, Dr.
My pleasure. Always like working with you, Cyrus.
Fantastic. So the reason that we wanted to interview you today for the Mastering Diabetes Online Summit is very simple. You are not an expert in plant-based nutrition, and you don't claim to be, and that's totally fine. But the reason we want to interview you is because you have extensive experience in treating people with diabetes as a classically trained physician. Now, what we want to focus on today is an understanding how doctors think when it comes to the presentation of high blood glucose and its comorbidities. And then that way, our viewers can get a little inside knowledge into the head of their doctor to understand how their doctor has actually been trained in medical school. So many of our clients get super frustrated when they go to the doctor because they're making these large changes in their diet, and then they're often seeing reduced blood glucose variability, reduced A1Cs, reduced fasting blood glucose, weight loss, reduced cholesterol, you name it. And yet the feedback they get from their doctor is that their doctor only talks about medication use and has no idea about how to communicate with them about dietary change. So today I want to get inside your head, and I want our listeners to be able to learn from you so that they can understand how their doctor thinks. So first question, here we go. Suppose somebody comes to you and they come to your office and they present with the classical symptoms of pre-diabetes, which is slightly elevated fasting blood glucose, slightly elevated A1C, and perhaps maybe 20 or 30 pounds of excess body weight, okay? Give us a detailed insight into how your medical school training taught you to treat such a patient.
Metformin.
Okay, go into a little detail here.
Yeah, so I mean, the question, how does medical school train us to treat that of course we train people to treat people, right? But really the medical school training, it's more along the sides of there's a disease and there's a treatment, there's a pathophysiology behind it. And so follow evidence-based medicine guidelines on how to treat something. So basically what we've been trained is metformin is the first line agent to treating prediabetes and diabetes. If you have an A1C that's elevated, put them on metformin. Of course, there's also diet and lifestyle changes, and that's the right answer on the boards. Diet and lifestyle changes. So, hey, patient, here's some metformin, and why don't you do some diet and lifestyle changes, which traditionally means exercise more, eat less, right? Less calories, more calories out, less calories in, lose some weight. And I actually jokingly, I'm a hospitalist now, so I don't see a whole lot of pre-diabetes. That's more clinic stuff because the disease hasn't taken its hold yet. But I joke and say, you know what? If someone walks into my clinic and they're overweight, I say, lose weight. If they ask how, I say, well, I don't know, exercise more, eat less. Right? So there's very limited specifics on what does eat less or eat better and exercise more mean. And generally we give it back to the patients and say, hey, you figure out what that means. Do what you like doing. If you like walking, go walking. If you like swimming, swim. And then for those of us who get a little more at training, some more hands-on stuff in terms of dietary, it's add color to your plate or add more fruits and vegetables and eat less carbs and less processed foods. But it goes very little beyond that. Someone who's at pre-diabetic stages 1 is real early on. Their A1C is already under goal for the whole panel in terms of your annual metrics. So they don't count as needing any attention. And basically it's up to them to fix it themselves. And here's some metformin to help you.
Okay, so now suppose somebody comes in your office and they do have classic type 2 diabetes symptoms. So there's significantly elevated fasting blood glucose, A1C greater than 6.5%. Maybe they have 30 to 100 pounds extra weight. What would you do in that case based on your medical training?
Metformin, diet and lifestyle changes.
So it's the exact same prescription.
Sure, I mean, and now someone who is a better family physician who actually has a little bit more time might discuss the risks and benefits, the problems that diabetes can cause, why it's important to lose the weight and make those lifestyle changes. But again, the frontline treatment for someone with an elevated A1C is diet and lifestyle changes, which means exercise more, eat less, and then because your A1C is elevated, we'll give you some medications based on your comorbid conditions, but the first line agent is going to be metformin. There's really no difference. I'm obviously being hyperbolic here, right? Of course there's difference. And of course there's going to be some physicians who are better trained at what diet and lifestyle means and others. But traditionally, diabetes is how you diagnose it, A1C over a certain number. What do you do? Metformin. If A1C is over 9, they probably need insulin. So why don't you get them on that? But insulin is scary. So why don't you warm them up to it over whatever time period you choose based on your level of discomfort? The positive side of this, of course, is going to be, we do want you to exercise. We do want you to lose the weight. If you lose the weight at pre-diabetes or just over the A1C of 6.5, you can reverse it, right? There's going to be that education of, hey, you are overweight, you're on your way to diabetes, or you have diabetes, but it's not too late. If you lose the weight, exercise more, eat less, and help you out with this medication, you can undo it. And if the A1C is really high and it's like, whoa, dude, it's too late, damage done, let's just get this under control. Here's a bunch of meds and hopefully we can get you through this. And then why don't you go talk to the nurse for diabetic education? Why don't you ever go to a diabetic educator to talk about your diet and lifestyle changes? Now, we don't get taught that in medical school. No one's going to say, oh, shift the burden of education to someone else. That's the answer on the test. No, it's diet and lifestyle changes. And in reality, in practice, because what we end up doing is documentation, filling out forms, billing, back-end crap, and because we have to see 30 patients in a day in order to break even, well, the patient in front of us gets 5 minutes. And that people probably have experienced that, especially at subspecialty clinics, where it's easy to say, hey, you have met this threshold, here's your medication. Come back. If you're not at goal, here's your next set of medication. And by the way, we have people who you can go talk to about your lifestyle and diet. Diabetic educator, the nursing educator, diabetic, everybody in this giant team of healthcare providers that can get you what you need. So no one says in medical school, you're going to shift the blame and burden to someone else. But in practice, that's what ends up happening. And through residency, as you train that way, you think, well, I know the medicine, I know the meds, I know the pathophysiology of disease. Those other people, magic black box that I don't really understand, they must have the answers over there. So I do my role, shift them over to someone else. I'm not saying you should do that, but I'm saying that's what happens.
Okay, this is actually brilliant because I think what you're explaining is actually the classical experience that a lot of patients with diabetes get from their doctor, a very limited amount of time, and then let me just outsource you to someone else, and then you can talk with them about it. So when it comes to medication, you talked about metformin. So let's go into a little bit of detail here. What is metformin and how does it work?
Metformin is a biguanide. Ooh, it's like the only one. Metformin is actually one of the best medications we have because it's an insulin sensitizer. Now, if you actually talk to Dr. Khambatta, he probably knows a lot more about intracellular cycles, about metformin and what it does. But for me, what I teach and what I was taught is basically metformin is an insulin sensitizer. Sensitizer means doesn't make any more insulin and doesn't mean injection of any more insulin. It just makes the insulin you already have better, which effectively it reverses the pathology of type 2 diabetes where they develop insulin resistance. You essentially undo the resistance. Now you can't bring it back to normal. The benefits of this is that you can't cause low blood sugar, hypoglycemia, because you're sensitizing insulin. The body's already making too much. It can't respond to it. All of a sudden it does. And because insulin causes deposition of fat into adipose tissue, there's no excess insulin. And in fact, your body needs less if it's sensitized, so it doesn't cause any weight gain. So the absence of weight gain and the absence of hypoglycemia make it an ideal first-line medication. Also, it's super old, so it's on $4 formularies everywhere. It's generic. The problem is that patients probably notice it causes really bad diarrhea. So the goal of metformin is to be on 1,000 milligrams twice a day. And you start off at 500 once or twice a day. And the person has terrible diarrhea. And at the end of two weeks or so, the diarrhea stops. So you tell them to increase the dose. Diarrhea comes back 2 weeks later, goes away, increase the dose. And you keep going until you're at 1,000 twice a day. And because it's an insulin sensitizer and not an insulin secretor, you can go to the max dose. There's no titration. You're supposed to be on 1,000 twice a day because there's no risk of hypoglycemia. Problem, of course, is that if you have renal failure or you have a disease that predisposes you to acute kidney injury, like heart failure, it can cause a lactic acidosis. Very, very rare, and most people don't have that happen to them. But the things to look out for are metformin, no weight gain, no hypoglycemia, but if kidney problems can cause lactic acidosis, which would require hospitalization, and the patient wouldn't know it until they went into the hospital.
This is fantastic. Okay, now let's talk about sulfonylureas because they act a little bit differently. So these are medications like glipizide or glyburide. How do they work, and what are the side effects of those?
So the ADA actually, back in the day when I was training, was very explicit. It was metformin first, then sulfonylureas, because they were old, they were tested, and they're cheap. Now I think pharma's got its fingers in everything, so the ADA says, do whatever you want, pick whatever. The good thing about that old way of thinking was that metformin, insulin sensitizer, and then if that doesn't work, add on sulfonylurea, was that it's cheap and it's been around a while, so we can anticipate what might happen. Sulfonylureas are insulin secretagogues. That is, when you take them, they tell your pancreas to work harder and you make more insulin. Now, if you have type 2 diabetes, you have insulin resistance and your body's been trying to make more, but it's been failing. The sulfonylurea says, oh yeah, work harder. It works, right? The A1C comes down, the blood sugar is controlled, but it's effectively giving yourself insulin, only that insulin comes from your own pancreas. Because it's more insulin, of course, the risk then is that you can cause hypoglycemia, low blood sugar. And because the sulfonylureas are cleared by the kidney, there's kidneys again, if you have chronic kidney disease or you suffer an acute kidney injury from, say, dehydration, you can actually provoke a low blood sugar when previously it wasn't causing one, because these sulfonylureas are normally cleared by the kidney. If you have kidney problems, you can't clear it as much. It's as if you took too much insulin. These are also cheap, generally not good for the elderly, not good for chronic kidney disease, but they still do work, and you can use them in kidney disease just at a reduced dose. What they do is push more insulin out of your pancreas. But more insulin, more fat, increased weight.
Are there any other side effects worth mentioning?
There probably are, and I don't know them all. And the big things are diarrhea for metformin and low blood sugar for kidney disease. That's what I tell people to look out for. I actually don't discuss any other side effects, and I don't even teach them. So like in my process brain, I don't have any. Like in both of these medications are in my top 50. That is the 50 medications that I know the name and dose of, and I use frequently. Those are the ones I go to. So everything has way more than that, but those are the high things that actually come up in medical training. Right? The problem with are there other side effects is that when something goes through a phase 3 trial, someone has to report any symptom they have while they're on it. So if someone gets the flu, they'll report fevers, myalgia, diarrhea, nausea, vomiting, and then that has to go on the label for the medication that was being tested. So if you look at a label or even one of the online, try not to use a trade name, online medication repositories, you might see a long list of side effects, and even those that are potentially serious, but those aren't seen very often. So after you get a bunch of clinical experience, it boils down to metformin, lactic acidosis, diarrhea, sulfonylureas, hypoglycemia.
I assume they list the side effects in order of how frequently they happen. Would that be accurate?
They don't. No. So when you get a label, it'll be common. That is, these are the things a lot of people reported, and severe. and the severe ones are life-threatening. But something like nausea or diarrhea reported subjectively is going to be common, because during a 6-month period, how many times have you had loose stools? Probably more than once, and you're supposed to report it. And there's no way 86% have reported this, or 20, it's just a list. So it's really, really hard for people training in medical school to figure out, well, which one of these is real. And it's even harder for patients to know, well, what should I actually look out for? When should I stop this medication? When should I bring this up? And so if someone came to me and said, I have this symptom, and it wasn't in my checklist of experience, I'd be like, okay, I wouldn't even consider one of these medications to be the cause. Now, if they kept coming back over and over and over again, and they were on 2 medications, I'd say, this sounds suspicious. This isn't just like an acute problem that's probably viral related. You keep coming back with the same thing. Okay, let's try a medication switch. But if that complaint isn't in my own data bank of what I should look out for that medication, I skip it. So it often takes 2 or 3 presentations, and eventually someone just goes to the hospital or to another doctor, and then that person take the time to do a real close drug interaction or side effect list. They say, hey, well, maybe this could be it, and make the switch.
Got it.
Okay, so you've talked about the kidney a little bit. You talked about chronic kidney disease and renal failure. So let's go into a little detail here. There's a class of drugs called SGLT2 inhibitors, like Invokana and Jardiance. How do they work, and what are the side effects of those?
So bias, I have reported 4 of the major adverse events from these medications. And when I was at the ADA conference a year and a half ago, I walked up to Invokana and they said, oh, we know you. So I don't like these drugs at all. The mechanism of action is exactly the same as that puts type 1 diabetic into DKA, right? So the kidney can resorb only a certain amount of sugar, about 180 milligrams per deciliter. That's a pretty poorly controlled sugar, but lots of diabetics live with blood sugars higher than that. The sugar is filtered by the kidney, and the sugar goes through the kidney nephron and will end up in your urine. The body, the kidney, can only take back 180. So if your blood sugar is over 180, sugar is lost in the urine. That sounds like a great thing, right? My sugar is high, I want it out. The problem is that sugar is osmotically active. That is, water will follow it. So if you have sugar in your nephron, if you have sugar in your bladder, sugar in your urine, water is going with it. So the way patients go into DKA is that their sugar gets well above the 180 mark. And over a period of time, they dehydrate. Not only is it the lack of insulin, but also the massive dehydration that occurs that pushes someone into DKA, diabetic ketoacidosis, a diabetic emergency. These new SGLT2s block the absorption of sugar in the kidney. So they take that 180 resorption and drop it down to lower than that. The effect is sugar leaves your body into your urine. Yay, your sugar goes down. But now instead of going into DKA at over 180 and making this next number up, you go into DKA with a sugar over 100. So I have taken care of 4 patients who have had euglycemic DKA. They were in diabetic ketoacidosis and had a normal blood sugar value. I hate these meds, but keep in mind, I only see the cases that result in catastrophic diabetic emergency. And this has happened not in type 1s, but in type 2s. Because water follows the sugar, there is technically the potential to use these intentionally as a diuretic. So in patients who have heart failure and diabetes, when fluid and sugar is a problem, the extra diuretic effect, the loss of that fluid along with the sugar, might be beneficial. Now, there's a lot of people who disagree with me, lots of people who say this is a good med. I've seen the catastrophic results a couple of times, such that the drug companies know my name. So I recommend strongly against them when you can use something else, but there might be a use for these medications, specifically in heart failure when diuresis is desired. But I want to say it again. I saw this commercial like 2 years ago, and I said to myself, literally the mechanism of action of this medication is the same mechanism of action that puts people into diabetic ketoacidosis, and those who are not type 1s are almost there, into hyperosmotic non-ketotic coma. So kind of surprised they got through, might have a benefit. As a blanket statement, I'd recommend against them altogether.
Okay, there's another class of drugs called GLP-1 inhibitors, and I know a lot of our patients are prescribed those medications to deal with blood glucose control. So can you go into a little detail here about what GLP-1s are and how they function?
Yeah, the GLP-1s are sort of this magic wand that's come out. I don't know where it's going to end up. Lots of excitement. GLP-1s, don't really sure how they work. The problem is that they are injectable. So what I used to teach was 2 oral anti-glycemic agents, 2 diabetes meds, still not controlled, start insulin. Now the ADA has released 2 diabetic medications, not working, add a GLP-1. GLP-1s are injectable. Insulins are injectable. Insulins cause weight gain. GLP-1s cause weight loss. GLP-1s affect a bunch of different stuff, and we're not really sure how it works, but it works on the satiety center. It might work to make more insulin. It might make desensitize insulin. We're not really sure how it. But what we do know is that if you start taking a GLP-1, you can drop your A1C by 1. Very, very promising. The problem is that ADA 2016, there was a huge push. And basically what came out was GLP-1s work. GLP-1s work only when they're studied. GLP-1s cause problems with the pancreas and stomach. Ooh, pancreatic cancer and pancreatitis. Eesh. So for the patients that they're going to work for, type 2s only, who use it and don't have any gastrointestinal problems, awesome, right? They cause weight loss. You don't have to go on insulin. And some of them are like every 3 days or once a week. Sounds very appealing. And I think that people should try them. But if anybody who gets on them has any sensation of pain in their upper abdomen, nausea, vomiting, or diarrhea, get off it. Type 1 diabetics are not helped at all by it. Get off it. GLP-1s could be the way we prevent people from getting on insulin if their diabetes is worsening before we get them under control with diet and lifestyle. But I do want to warn people that there is a very high chance that this could be harmful. We just don't know yet, in the way of pancreatic cancer and pancreatitis, which suck worse than diabetes. So if someone recommends them, it is because it is a clear recommendation from the ADA. Type 2 diabetics, not controlled on 2 pills, use an injectable. Injectable is GLP-1. But I'm telling people, if you have a problem with your stomach of any kind when you're on the GLP-1, get off it. But when I say get off it, it means you have to go to another injectable called insulin.
Okay, this is fascinating information. So you mentioned type 1 diabetes and DKA. So what is diabetic ketoacidosis? What are the telltale signs of type 1 diabetes, and how would you treat such a patient?
Okay, so in pediatrics, you usually get diagnosed with type 1 as a kid. What I train people to look for is polydipsia, polyuria, and polyphagia. What that means is you're drinking a lot, you're eating a lot, you're peeing a lot, but you lose weight. That is because the way DKA happens is that effectively you lose all your insulin. You're eating, you got plenty of sugar in your blood. In fact, you got so much sugar in your blood, your kidney can't reabsorb it all, so you're getting dehydrated. Thus, lots of drinking and lots of peeing. But because you have no or very little insulin, your body can't use the sugar that's there. It can't get from the bloodstream into the cells. And your brain is like, I need something. I'm not getting the sugar I'm supposed to get, so give me something else. And what happens is your body goes into a state of starvation. Even though you're eating, even though you've got lots of sugar, the body thinks it's in starvation, so releases free fatty acids from everywhere. And that's an attempt to feed your brain. Diabetic, that is, you have diabetes, so sugar is high. Keto acids, that is the fatty acids that are released to replace the source of fuel for your brain. And then the acidosis is because those keto acids build up, the pH of your blood drops. Now, DKA itself is a life-threatening emergency. Drinking a lot, eating a lot, peeing a lot, and losing weight anyway are the signs of someone who has new onset type 1 diabetes. You can make the diagnosis and intervene before DKA. Someone who has type 1 who doesn't get intervened on in time, or someone with type 1 who doesn't take their insulin, their bodies don't make, pushes themselves into the state of starvation, and they go into DKA. They will also experience polypsia, polyuria, polyphagia, eating a lot, drinking a lot, peeing a lot. And when their pH begins to go down, they don't know their pH is down. I do, because I stick a needle in their wrist and draw out the blood. As they get acidotic, as they continue to starve, their brain doesn't work, they get confused. And eventually will go into a coma. Coma is the next stage closest to death. As a paramedic, we were trained to try to smell that juicy fruit or the really sweet odor of DKA. I don't smell that well, but some people can do it. More importantly, eating a lot, drinking a lot, peeing a lot, but feeling the fatigue, confusion, and eventual coma are the signs of someone in DKA. If you come in DKA, we will stratify how bad you are based on the pH level of your blood, how confused you are, and how much fluid we need to fix things. If you're in a coma or your pH is less than 7, you are the most severe you can get before death. If you are not so confused but a little off and your pH is between 7.0 and 7.2, you're still going to the intensive care unit. If someone manages to come in a little early, that is their pH is between 7.2 and the normal 7.4, and they are not confused at all, but they have some of these keto acids floating around their blood, their sugar is high, we may be able to get by with giving someone a bunch of fluid and some insulin. But at that point, the DKA stage, the life-threatening emergency, you're being hospitalized, you get IV insulin, not just sub-Q injections, and a ton of volume because you are so dehydrated from the loss of sugar in the kidneys, and your brain and all organs are starving for energy. We have to give you the volume, give you the insulin, and usually, this is confusing, once we get the sugar down to a certain level, you still need the insulin to correct the acidosis. We may even add sugar to the fluids towards the end.
Okay, so you touched on insulin here, and I think this is a really important topic here. In the case of type 1 diabetes, most people who are diagnosed in the early stages of their diagnosis, they want to get off of insulin as much as possible. So they do everything they possibly can, and they oftentimes adopt a low carbohydrate diet in order to reduce their insulin exposure or the amount of insulin they need. We try and teach people insulin is not your enemy. It's a required biological hormone required for life. Can you go into a little bit of detail here into why it's important to understand that insulin itself is not necessarily a dangerous hormone, but it's actually required for life?
Sure. And actually that perception, insulin is scary, everyone has it. Either it's a sign of failure because you couldn't control your disease, or what people learn is, well, if I take too much, I die from a low blood sugar. And so that baseline, that tagline, people hear and they're like, well, I'll forget it. I don't want to die. The problem is, especially with type 1s, in type 1 diabetes, you can't make any insulin, right? There's autoimmune destruction of the cells of the pancreas that inherently make insulin. And so if you don't have insulin making cells, you literally cannot make any. Now, there's obviously variations, but let's just say type 1 has no insulin production from their pancreas. You need sugar to live, right? We just talked about DKA. Fatty acids cause a problem. So the brain, the muscles, all of your organs need sugar. So you eat them. If your body doesn't make any insulin, none of those organs can get the sugar, right? In order to get from the blood into the cells, insulin has to act. So if you have no insulin, you can have plenty of sugar in your blood, but none of your cells are getting it, and that's what pushes you to DKA. Insulin is mandatory. You have to have it. But in type 1s, they make none. So you have to then supply it exogenously, that is through injections. Now, it can get very complicated, right? And the way a normal pancreas without type 1 diabetes works is there's always a little bit of insulin around, and that keeps your blood sugar stable. When you eat something, your blood sugar begins to go up. And a normal functioning pancreas says, whoop, hey, blood sugar is going up. Let's excrete a little bit extra insulin to control that. When the blood sugar begins to come back down to normal, the extra insulin turns off. That's sort of the basal insulin always around, and then the bolus insulin with meals. When we ask diabetics, especially type 1s, to inject insulin, what we try to ask them to do is to mimic what the pancreas normally does in a regular patient. That is, there's always a little bit of insulin around. That's your basal, once or twice a day. And then your bolus, which is prandial. And the problem is that a non-diseased pancreas has a sensor that says, ooh, sugar's too high, make more insulin. Ooh, sugar's going down, stop that insulin. You, the diabetic who's injecting, doesn't have that, right? So you just have to give yourself some. And so what we do is try to train people to get as close to what's needed. The idea is the insulin you take right now is going to cover the food you're about to eat. So you inject, eat. Now, if you're right, at the next check, your sugar is going to be in normal ranges. If you were wrong, you can't go back in time, right? What you can do instead is say, okay, well, I missed that. I didn't give myself the right amount for the food I was about to eat. So I'm going to give myself a little extra. Right? That's correctional insulin. So you give yourself the correctional insulin, and then you're about to eat another meal, so you have to give yourself some insulin for that meal. Now, in the very beginning of this process, it is literally guessing. There's some formulas out there that say, oh, maybe based on this weight, and blah, 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 blah. But what it comes down to is you just try it and see what happens. And the more information you have, the more educated the guess, right? How many carbohydrates are in your coming meal? What's your sensitivity? You start off at a number that's way, way below what you need. But then over time, you titrate it. You zero it in. And a couple times, you'll have a really high reading because you ate a cake and didn't give yourself enough. Or you gave yourself the cake dose and ate a salad, and you'll have a hypo. But then you learn from that, and eventually you kind of, if you're doing it correctly, what you'll do is you'll have all these and then all of a sudden it'll start to even out and be controlled. The problem is that for a lot of people starting insulin, the idea of injecting insulin up to 5 times a day or more, if you're going to be really savvy, and pricking your finger as many times is sort of like, well, I don't want to do that, period. And then they hear, ooh, insulin could kill me if I take too much. They say, forget it, no. Well, the problem is that your body needs insulin to live. And while you don't have to do it 5 times per day, the whole point is to try to simulate what the regular non-diseased pancreas would do if it were working. And it's hard to do that, but with a little bit of training, you just start off taking the same amount. Doesn't matter if you're off. And then you sort of dial it in and get them closer to the dose. You keep your calories the same. And you learn how to carb count, and you learn how to add extra, the correctional. And all of a sudden, after a couple of weeks or even months, you're so good at it, you kind of just look at the food, you know about how much, and you give yourself the right amount. But it does require a lot of vigilance. Now, type 1s must have insulin because they have none of their own. But the standard of care that we get taught is A1C over 9 needs insulin. The thing is that type 2 diabetics have insulin resistance. They still make insulin. So we can get by with maybe not being as rigorous because we're not trying to emulate exactly what the pancreas does because the pancreas is already doing it. The higher the A1C, the more necessary insulin is because all the medications that we have, everything we do, basically mean either increased insulin sensitivity or somehow more insulin, except for those SGLT2s we're talking about. And when it comes down to it, the way you control the blood sugar the best is with insulin. Now, I don't know, I probably shouldn't go down to type 2 actually, because that's like brings a whole lot of questions about like, should the risk of increasing to obesity and the cycle.
Okay.
So probably leave the whole type 2.
Okay. I mean, that's actually an important point though. I mean, I think you're onto something there. And the thing we teach people is that like, we're trying to say insulin's not the enemy because yes, it can lead to weight gain. But like if you're a type 2 and your pancreas is exhausted and you need some like in the short term, it's not the end of the world. Like people are, it's like it can be
that's a good message actually. That fits right in. Like that's not what I would teach, but that's actually a good message for me to bring up here.
Yeah.
I can do that actually, yeah.
Right, cool.
Like the short, like because and so in reality, if you get put on insulin, you're going to be in this vicious cycle where you are going to gain weight. You're going to need more insulin and more weight and more insulin, more weight, more insulin. It's sort of actually for dose doctor, shush, don't point this out there. It's like we're going to be recurring customers forever, right? We keep increasing their insulin. They keep going up in weight. They keep increasing their insulin. Like we'll always have people that fall back out of goal. But I think that in context of you guys, like actually it's important to say, well, if you need a little insulin to give your pancreas some help and implement the lifestyle changes,
Yes.
that's actually really important.
Yeah.
Okay. So let's go back to, if you lose a lot of weight, you can probably reduce it, but classically what we get trained is an A1C over 9 is going to require insulin. Now, insulin can lead to weight gain. And this is the people that, this is the part that scares people also. They hear that insulin causes weight gain. And since they've already been told weight gain caused their diabetes to begin with, they think, well, if I go on insulin, it's only going to get worse. And that actually, brace for it, is true. If you do nothing else other than go on insulin, you are going to gain weight and your diabetes can get worse. And that'll increase your insulin requirements. But here's the thing. If your A1C is over 9, the risk to your eyes, your kidneys, your feet, your heart, your brain, your life is so elevated that it doesn't matter. We just have to control the blood sugar, reduce the risk of all that. The damage done is done. And you can reverse the damage to your capillaries, your arteries. You can't undo the heart attack or undo the stroke, but you can significantly reduce the risk of those things happening in the future if you control your blood sugar. In the short term, controlling your blood sugar must be done with insulin. A1C over 9, especially in the double digits. There's nothing you're going to do in the short term that's going to get adequate control of that blood sugar. That sucks to hear, right? It's like, well, I didn't know my diabetes was that bad. Now I have to prick my finger and stick a needle in my belly. Well, yes. Right? The question is, do you want to feel a little pinprick or do you want to have a stroke? The good thing, though, is that once the blood sugar is controlled, if you do more than just the insulin, right? If you do those dietary and lifestyle changes, you can substantially reduce the amount of insulin you need. You may not need to do it every meal and the basal bolus thing that we tell type 1s to do. You may get it down to once a day. You may get off it. The problem is that you have to be aggressive with your lifestyle changes, with your diet and your exercise in order to undo that very high A1C, losing hundreds of pounds, completely radicalizing what you do in terms of lifestyle, which is really hard. And we don't have medically very many protocols or decent plans to get someone from an A1C of 12 to an A1C of 7 any other way than insulin. So it's up to people who have really good ideas and who are very willing and committed to a huge lifestyle change that can actually make that reversal happen. I'll say again, though, type 1s must have insulin because they don't make any of their own. They can reduce the amount of insulin they need, but a type 1 diabetic should be committed to a lifetime of injecting insulin.
Okay, this is absolute gold. I love this because this is oftentimes a lot of our clients and a lot of people with diabetes tell us that they never learned this sort of like classical pathophysiology of diabetes, of pre-diabetes, of type 2 diabetes, of type 1 diabetes. They just go to the doctor and the doctor basically says, here, do this, see you later. And so learning, the actual mechanism of what's going wrong and how these medications are actually potentially helping in certain situations is really valuable. So here's my question to you. Why don't doctors receive nutrition training in medical school? Is that something that we can change, and how do we do it?
Absolutely. I mean, a little plug at the beginning. We're working with Dr. Khambatta over here to build a nutritional course for medical students. I think that, and this is a problem with medical education in general, I think that people teach what they were taught and knowledge is handed down, and nowhere in there was really good nutrition. We talk about vitamin deficiencies and vitamin excess. We talk about calorie-related obesity, but there's no real knowledge source for lifestyle diet. And people have to go out and find it on their own. And then if someone gets really into it, well, they get labeled as a crunchy granola who's really into seeds and nuts and not into medicine. Right? So there's actually a stigma that gets placed on people who try to advocate for true nutrition. Problem, though, is that some people get really into it and then they're trying to teach something useful, But what people hear is, well, I'd rather you go get your magnesium supplement than your diuretic for heart failure. And then they lose all credibility. That may not be what they're saying, but there's this, for one, there's no one to teach it. Two, there's a stigma for people who try. And three, it's not pathophysiology, presentation, diagnosis, treatment. The treatment is diet and lifestyle. Let someone else take care of it. So I think that there's, it's not that no one wants to learn it. It's not that no one wants to teach it. I just don't think that there's a really good avenue or source that combines the med school mentality with the reality of diet, especially since our commercial world right now is littered with diets and fads and paleo and low carb and starvation and ketosis and blah, 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 blah. The physicians that are taking care of patients, the medical students, well, they went to medical school, they're losing weight. So they're trying the paleo diet, right? No one says that's not going to work. They see the same TV advertisements that everyone else does. So there's no real good way of, well, one, there's no good way of having evidence-based research to do a randomized controlled trial for one diet over another in exclusion of other factors. So the academics in their ivory towers are going to completely discredit anything that comes that way. Then there's the fact that humans are doctors, right? Doctors are humans, so that they're exposed to the same garbage that's out there and they don't know what's good and what's not. And they might have their own short-term success and maybe want to promote it. And then the third thing is anyone who actually knows it may be promoting it, and it appears to be promoting it in the exclusion of real medicine, so there's a stigma against them. So what we have to do in order to change that is get somebody who's creditable, get in front of medical students very early, and then do it in a way that sticks with their mindset of pathophysiology and linking what the diet does as though the diet were a medication. So kind of integrates with the way they're learning what they're being taught, and you get it taught from an early stage. This is sort of what we've done with online med ed in general. There's a significant burnout in the medical field, a high suicide rates, and that's because med school sucks, right? You dedicate your life for 4 years, you go into 200,000 or more in debt, you work 80 hours a week just studying for the benefit of taking a test to maybe one day be a doctor. Well, that sucks, right? That sensation's awful. And you're at the bottom of a 10-year training track. So you get crapped on all the time. And because you've been crapped on, when you get up to the next level, you're like, finally, the next level. Well, you're still getting crapped on, right? And so when you look up, you see 10 years of people who've been crapped on. Well, they don't feel very good, right? And then so as you look up at your mentors, you think, well, that's the way things are supposed to be, so I'm going to continue to be like that. That same concept, I think, is in the case of nutrition, where if we break the cycle, if we make people happy in medical school, they stay happy in residency, and they stay happy in practice because we make med school not suck, then as people look up, they'll see happy people on the other side. If what we do is break the cycle and stigma against nutrition, get people in early, teach them in the way they'll believe it and that they'll be able to understand it, retain it, and use it, the future generations of physicians who look up see, well, diet and lifestyle actually mean something now, and it's real. So that's not a very good short-term solution. Short-term solution is going to be, you got to deal with what doctors are, and it's going to take like 15 years for the old farts to clear out and the new people to come in. But let's start that cycle now of training the new people who are coming in to be ready to make a positive change. In the meantime, patients just have to find alternative sources, people who do care, who do know what they're talking about. And even though that may be fatty or may be real, you have to try other things than your doctor's office, because your doctor's office is going to be the one who increases your insulin and adds metformin.
Yeah, I mean, this is amazing. And obviously, we couldn't agree more that we want to start changing this for doctors. And you're up to some amazing work. So you have founded 2 powerful online platforms to help medical students and doctors. So we'd like you to tell our listeners all about them, and don't be shy. Tell them how amazing these platforms are.
Okay, sure. Online Med Ed is my first. That's a clinical learning platform for medical students in their clinical years. That is, they finish the basic science section and they are now going on to the wards for the first time. Med school sucks, as I alluded to. Med school is really hard. And the problem is that no one gets taught how to teach. And anyone who teaches well generally has gained a level of responsibility in administrative or research roles that they don't have time to teach. So what happens is medical students come into the clinical wards and think, well, here's my opportunity. I've finally gotten through that first 2 years. Now I'm gonna start seeing patients. And they have no way to learn what they need to learn in the time they have it. They're spending 60, 80 hours a day seeing patients in the hospital. Then they're expected to go home and learn a brand new set of information than they had in the previous 2 years. But now they have 80 hours less a week to do it. So this all started when I was in medical school. Basically, I made what I needed, what I wanted. I went into an OBGYN lecture about contraception. And at the time, it was, Yaz was on TV, and that was basically all there was before rings and implants, et cetera. And I walked into that lecture thinking, man, I don't know anything about contraception. I was, condoms and Yaz. And then at the end of 2 hours, phenomenal lecturing. The dude used the whiteboard, we drew pictures, colors, arrows. Like, I walked out thinking, I don't know much about contraception, condoms and Yaz. And the problem was that the dude was talking to reproductive endocrinologists, which is 8 years away from where we were as third-year medical students. And I said, you have to be able to do this better. So what Online Med Ed does is it takes a learning paradigm we coined called PACE, which stands for Prime, Acquire, Challenge, Enforce. Prime, read the notes. Acquire, watch the videos. Challenge, do some questions, some clinical vignettes. And Enforce are flashcards and sort of our review book. The idea is that it maximizes efficiency and effectiveness in memory and retention. The videos are only 15 minutes long, not 2 hours. And we teach students at the level they need to learn it. So what Online Med Ed does, it de-stresses and decompresses the process of learning medical knowledge. We make it faster. And even though it's faster, you have a better understanding and you remember it better than if you try to read a textbook with 1,000 pages in it, which is what a lot of people try. And the problem with medical school is that there's only one currency, and that is your grade. And if you don't know enough, and if you can't get the answer right on the test, nothing else about your experience matters, which is the complete opposite of what we want, right? Medicine is experiential. You have to know stuff, but you go through medical school and residency to practice. If all you care about is what's the answer on the test, you forget the person in front of you. So what we're trying to do is basically make the medical knowledge portion of medical school easy. You blow through it, you memorize, you learn it. Now you can pay attention to being a better person, a better doctor, a better everything else, right? Being a good doctor is not knowing a bunch of stuff. It's knowing a bunch of stuff and being a great person. And up to this point, people haven't been able to focus on being a great person. Perfect example, diet and lifestyle aren't tested. So why do people know them? They're not on the test. But if you can ace the test and all of a sudden you have an entire year in your fourth year to do something else, well, maybe you'll take a course on what diet and lifestyle means, or communication, or leadership, or whatever the case may be. Online Med Ed's got 100,000 users each month, more learners than there are medical students in the world. So obviously multiple people are coming, nurse practitioners, physicians, assistants, anyone who wants to know the foundation of medicine. Right now, there's obviously more to medicine than a 15-minute video, right? That's why you go into residency. What we're trying to build are well-rounded physicians that anyone who is a doctor or at that stage of healthcare provider, DO and PA, that they have a good foundation. And then they go on to residency, or they actually go into their field to train and learn the truth. Fundamental principle, understanding is more important than truth. We've been wildly successful, and that's because our videos are free. Right. We believe that medical knowledge belongs to everyone, so medical education should be accessible to everyone. Now, if you want to do well on the test, we do have a freemium subscription. You get the notes and the questions and all the bonus stuff to help you do better on the test for a small fee. But for the most part, our mission is to bring more medical education to more people around the world for less, or for free in our case. So you take the burden of cost away, you give them really good lectures that are honed in at what they need to know at the level they need to know it. Students all of a sudden learn stuff, do better on their tests, and are more mentally prepared to engage other facets of being a physician, like nutrition and whatever else they want. The second company was Dose Doctor, is Dose Doctor. Dose Doctor is a online chronic management platform. It started off with diabetes, and this came from my own training, right? I am from Connecticut originally, but I moved to Louisiana for post-Katrina era. I did my medical school training there and then residency thereafter. And so I was seeing the people the rest of the country had forgotten, right? Louisiana, most people don't know where that it is, except for New Orleans, there's Mardi Gras. And after the storm, we lost a lot of resources and a lot of people. And I kept seeing patients in my charity clinic, the free ones, right, for the indigent populations who were desperate to help themselves. And they couldn't. It took them a day and a half to get to clinic. The transportation system was garbage. They literally had to start their day at 5 a.m. to make a 1 p.m. appointment to be home by 10. Right? And that was their one appointment that day. The rest was just getting around town. So Louisiana has one of the worst rates of healthcare. We have the highest expenditures with the worst outcomes. And the story had been Louisianans are full of fat, dumb people who are lazy or doing it to themselves. And I wanted to change that narrative. And what I said was, well, there's not a lot of people here. There's not a lot of access to healthcare. There's a lot of poor people out in the middle of nowhere who have to drive 2 hours to see a physician. Maybe it's not their fault. Maybe they just need a tool. And this came from my free clinic where he was a newly diagnosed diabetic, insulin dependent. And I said, look, I can only see you once every 5 weeks. That's how my system's set up. So in the meantime, what I want you to do is this: check your sugar twice a day, increase your dose if. He came back 5 weeks later and said, hey, my sugars are controlled. I'm good, man. Good, thanks. I was like, okay. If this person could do it on their own with a piece of paper, how easy would it be if we made an app that did it for them? So what Dose Doctor is a mobile app that goes on the patient's phone. It's in simple instructions, and it takes complicated things like what we were talking about earlier, carb counting, correctional, skip basal dose, bolus dose, and says, right now, take this many units of this type of insulin. The patient does what they normally do. They pull out their glucometer, they prick their finger, they enter the glucose into the app. The app tells them how much to take in real time. This gives a tremendous amount of confidence, right? What people learn is insulin can kill me if I take too much. Well, the app just says, this is your doctor saying, take this much. So they do. They have the confidence of knowing what to do, and it's given to them in very simple to understand instructions. At the same time that they're doing this, all this information goes to a portal where a Dose Doctor physician, or now providers, we have nurse practitioners joining the team, will look at that information and make decisions with the patient. If the blood sugars are consistently high, contact the patient and say, hey, sugar's high, what's going on? And if it's just they got started on insulin and need to increase their dose or dial it in, they will. And sometimes, because we actually have that person-to-person interaction, it's not just autonomous, someone will say, I'm in Florida. I don't like my family. I'm overeating. I will be better next week. And then she was. Or there might be, hey, your sugars were controlled, but you're creeping up. What's going on? I've got diarrhea. You're on antibiotics. Go to the clinic. We saved a woman from DKA, and she got clean of her C. diff diarrhea just by oral antibiotics and a liter of fluid. So you combine this real-time feedback within the app, enter your blood sugar, how much insulin you take, with that physician oversight between clinic visits that makes small, frequent titrations and makes decisions with the patients, including that education piece of what they should be eating, what they shouldn't. And we allow them over time to get more aggressive for the type of insulin they're using. Did tremendously well. We did it twice, 2 pilots, took an A1C of 9.4 on average to an A1C of 6.3. We did that with the estimated blood sugars of 1 month and confirmed it at 3 months. Right? Dropped the A1C 3 points in 3 months. Compliance goes way up because patients know what to do. There's a constant reminder. They have real-time feedback. Patients do it, so their sugar's controlled. And then people can, because that change is so severe and swift, they actually feel the change in their blood sugar. Now, what Dose Doctor does not do is offer the diet and lifestyle changes, right? We just get their sugars under control. And then because we're working with their healthcare team, we don't take over. We're working with their primary care. We leave it to the primary care team. Now, instead of having to worry about insulin doses, which are just as scary for physicians as they are for patients, We handle that hard part. Now the physician that's their primary, instead of spending 5 minutes increasing their insulin dose, they can spend those 5 minutes talking about diet and lifestyle changes. And this is like a new announcement, hot off the presses. We've actually released hypertension as well, which means we are able to do the same thing with self-monitored blood pressures and help titrate blood pressure medications based on diseases that respond to blood pressure, like heart failure, coronary artery disease, chronic kidney disease, stroke, vascular disease. So now it becomes an entire medication reminder system, as well as a data collection that patients are now self-monitoring their own problems at home, giving real-time feedback what to do right there in the moment. And then on top of that, between clinic visits, they're getting their medications titrated and a little bit of education that helps them do better. And once they sort of figure things out, they stay on the app, we monitor them for changes, and it basically acts as a reminder system. So both online med ed, making it easier for doctors, and Dose Doctor, making it easier for patients, are ways of leveraging technology to make medical training and medical practice better, hopefully more cost effective and better for the people it's targeting. Online med ed, the students, and Dose Doctor, the patients.
This is really brilliant. Really brilliant. I mean, the work you're doing is incredible.
Yes, indeed. I'm pretty excited by it, actually. Yes. Everyone talks about how like healthcare system's messed up and how we have to change everything and how we have to do something. And then we don't, right? We just like do more of the same thing. And everyone knows medical school sucks. Everyone knows it's like a rite of passage. Like, no, we just do it better, which means different than what we've been doing. We can actually make a huge impact in healthcare. And that's what we're going for.
I love it. I've had the pleasure of being able to work with you directly, and I'm looking forward to doing a lot more of that in the future as we develop a more nutrition training curriculum for medical students and for doctors. And I just want to say thank you so much for taking the time to be with us here today. I mean, I'm sitting here learning so much from you, and I'm in this field of diabetes, and I understand a lot of things, but even then I'm listening to you talk, and I'm like, oh, I didn't know that. I didn't know that. I didn't know that. So, you're a wealth of knowledge, and I know that our listeners are going to absolutely love what you have to say. So thanks again for being here. We really appreciate it.
Thank you so much again for joining us. This has been really, really valuable information, like Cyrus said, for us. And I think our audience is going to really learn a lot. So thanks again. Really appreciate your time.
My pleasure. Thanks, guys.